Okay. Thanks very much, Greg. It is really pleasant to be here. This is completely a new departure for me. I have no medical background. I have no homeopathic background. So I'm coming at this completely left field. And as Greg said, this came about because my background is really looking at higher education. And myself and my colleague, Professor Ian McNichol, we have been studying the impact of higher education for very many years, going back to the 1990s. And in particular, in recent years, we've looked at aspects of the broader economic and social value generation of higher education. And so, in discussion with Greg, we were saying, well, look, are there kind of techniques that could be used, things that we've done in higher education that could be useful to yourselves when you're looking at the value generated by homeopathy? Are there things that that could be brought to it? One of the things I would point out, when we started looking at higher education in the early 1990s, this might sound a bit strange now, but people did not mention higher education and any kind of link to the economy at all. Now, that's almost inconceivable today. And I would say that certainly some of our work in the early 1990s contributed to actually making people aware that higher education was important to the economy. Some people would argue it's gone a wee bit far these days, but this is by looking at it from that perspective, we managed to change the tenor of the debate somewhat. Now, what we were trying to do is to see if similar approaches could be used for homeopathy. Now, one important thing to stress is this is in relation to public funding for homeopathy. Privately funded homeopathy, well, the private sector is a private sector. If people are interested in it or whatever, they will pay for it. But the issue is public funding, particularly these days when there seems to be a progressive withdrawal of any public funding in the UK for homeopathy. So let's see, we're looking, can we make arguments? Is there a case in that way? Now, what do we do? This was a relatively small-scale project which we looked at it over the summer. It was desk-based. Now, we started out with extensive research or reading around the subject. Now, a lot of this, obviously, is totally familiar to yourselves. You're immersed in it. That, I guess, is probably notorious now, that 2010 House of Commons Technology Committee report and all the piles of evidence that went in that was submitted to the committee. We looked at things like some of the subsequent reviews undertaken, the report from the recent consultation this year in Liverpool. Also, another one I found was the 2014 NHS Lanarkshire Board review. And so we were looking at all of these. We had a bit of a look at the Australia report as well. And I thought Rachel's presentation this morning was fantastic with the way they were almost forensically deconstructing the document. Some of the things that we wanted to look at as well, what other methods are used by NICE in terms of evaluation of health methodologies and health treatments. Also, the important thing, which is what we've done in higher education, is we're looking at other approaches that are recognised in the UK public sector. Not just in the UK public sector, by the way. We say the UK public sector because it's the approaches recommended by the Treasury, but they're very similar to those used by the World Bank, by all the international organisations as well. And we also have a small, while this was more desk-based and conceptual a study, we also did have some data from the Liverpool situation because of the consultation report being published. So I was able to look at some of the data there to do an example application of the valuation techniques. And then to suggest from where we were coming from possible ways forward. Now, from having read around everything, this ultimately is a kind of summary of what I was concluding at the time. And as I say, none of this is very likely to be new to you because you've been immersed in it, but some of it was actually quite shocking to me. I did come to the conclusion, clearly there seems to be a total impasse at the moment in terms of how do you demonstrate that homeopathy has any value, or should there be any reasons for public funding of it? Because it seems to be entirely stuck in this completely circular argument around scientific efficacy. And nothing else is being looked at. Nothing else seems to be allowed to be looked at. And a lot of this seems to have come as a result of that 2010 report, which it does strike me was, I think it's actually been used strongly subsequently, and in looking at the piles of evidence that was submitted to it, I'm not exactly, I wouldn't say I was convinced they actually treated all of that evidence correctly. It just came across as somewhat partial to me. The argument that we don't think it's scientifically plausible, we don't think there's any evidence for scientific efficacy. Yeah, okay, there's lots of patients say they like it. Okay, there's evidence for satisfaction, but that doesn't count. We don't count any of it because we don't agree with the first two things, so the rest of it isn't relevant. That's it. And that's basically what they were saying. In that case, well, what on earth can you do? There's this kind of pile, as far as I could see from the literature I was reading, including a lot of studies that were quite big, like that, the one of Bristol, which had over 6,000 patients over a 6-year period, with 70% reporting satisfaction and reporting some improvement. But all of that's going to put to one side. It doesn't matter because we don't believe the first two things. That's just struck me as quite shocking. And I thought, no, this is not something that we would do if we were looking at things in other fora, shall we say. For example, the evidence from that Bristol study, if I had that kind of evidence for some of the things we're looking at in relation to universities, I would be delighted. I would think it would be a bit of a slam dunk, actually. So this seems to be really stuck. I was really quite taken aback that there appears to be very little cognizance taken of patient views, and practically no cognizance at all of broader economic or social outcomes, which is very strange when you're talking about public funding, because so many decisions are made about public funding. They have to demonstrate that there's broader social benefit. They have to demonstrate there's a broader economic benefit. There's a whole book called the Treasury Green Book, which gives you guidelines on how you approach the evaluation of investments, public investments, policy projects, things like that. And they actually explain how to do it and how to go about it. And all of these things have to take into account broader economic and social outcomes. So the idea that when people are looking at should we fund homeopathy, that's just put to one side and they don't even look at it, was really quite shocking to me, to be honest with you. There is some economic evaluation literature, but there's not a great deal of it, and most often it's not generalisable. It's looking at very specific treatments for very specific ailments, which of course is fine, but it's difficult to go beyond that. And when you're looking at homeopathy as a general group, shall we say, that type of approach doesn't really work. So we were thinking, well, look, the way we've tried to look at benefits generated by higher education, which is the same way that the Treasury recommends you look at things, why can't we maybe try that? Why can't we try that with homeopathy? When I say, by the way, very little cognizance taken of broader economic and social outcomes, in the 2010 House of Commons review, they spent a lot of time on plausibility and efficacy and all that. But then they said, oh, the other important evidence things are cost effectiveness and effectiveness, but we didn't have enough information for any of that. So they didn't look at it. They even said that the West Kent NHS Trust had done a cost effectiveness review and concluded that that's why they closed it down. When the West Kent NHS Trust, in their evidence to the committee, had said they didn't do a cost effectiveness review. So I find all of this very, very peculiar. Also, when we got to another example is when NHS Lanarkshire decided to undertake a review of homeopathy services, they had tended to contract to the Glasgow Centre for Integrative Care, and I think there are people here from the Glasgow Centre. And one of the things that really struck me there was some of their own health groups in Lanarkshire were telling them to look at the broader impact. For example, the Area Clinical Forum and Allied Health Professional Advisory Committee said, quote, although we are not convinced of a scientific basis for continuing to fund homeopathic services, our advice is that in considering its decisions, NHSL should consider the possibility that resource utilisation in Lanarkshire may be greater than the direct saving from continuing to fund the service. Patients who presently attend the Glasgow service may make more GP visits, A&E visits, more demand on pain and psychological services if the service in Glasgow is not available. A judgment on the net gain or loss should be considered. Was it? No. None of that was actually looked at. There was no information on anything to do with economic or social gain. The board, whenever it made its decision, placed it firmly and squarely on the whole issue of scientific efficacy, and it blamed the House of Commons committee report. So, I mean, that report, frankly, which I personally think is quite flawed, has a lot to answer for in terms of its continuing influence. But if I can then take you forward about maybe ways to start looking at it a bit differently. Now, this is the kind of thing we do, like we would do if we're looking at something in higher education, like some kind of initiative. And this is how you would start to build the elements of evidence needed if you wanted to look at, say, cost-benefit analysis, whether the benefits being generated are greater than the costs incurred. And you would start to build a kind of logic mapping process. Essentially, and I think actually in this case it's relatively straightforward. And I'll give you an example. We use the Liverpool example later on in this context. So you basically look at the resources, the inputs, the activities, the outputs, the outcomes. What are you trying to achieve? Ultimately, you want to improve individual health and well-being, but not only. If you're talking about publicly funded health interventions, you're trying to improve general societal welfare. There are broader considerations as well. The individual is a member of society, so obviously them getting better helps improve society overall. But also there's knock-on effects. There's other effects on their families, their friends. There's other basically benefits to be considered and other things. Now, if we look at the sort of resources, inputs, activities, outputs and outcomes, it's quite easy, as you can see. Resources is what's available, the inputs is actually what you use, the activities is what you do, the outputs are what you actually produce, the deliverables, and those are the things that are within your control. Outcomes aren't totally within your control because there are other factors involved. However, by mapping it in this process, you show how you're trying to achieve the outcomes. Now, we will do that with higher education and then say, right, how do we start to value that? When you go into valuation, you go into looking at how do you value the outputs. So that would be the patients treated. And you try and measure that by quantifying it. Basically, to get an economic valuation, it's you identify what's produced, you quantify it, and then you price it. And that will give you the economic value. Now, when we say economic value, we don't necessarily mean financial value. We mean economic in the broadest sense, which is that broader value being generated for society. And you can do that, as I'll show you, by using various techniques. Once you've got that, you also then want to look at how far those outputs might contribute to outcomes. But I'll take that on a little bit here. Because again, to give you an idea of what sort of measures you all have heard of, are familiar with things like cost efficiency, cost effectiveness, technical efficiency, allocative efficiency, you know, all of this kind of thing. But this is actually the basic building blocks to create those kinds of measures. So again, if you've got your logic map where you're looking at the resources, inputs, activities, outputs, outcomes, you can actually start to develop measures of economy, efficiency and effectiveness. And I'll just briefly explain what those are in terms of economy is things like efficient procurement. Are you using that in the best way? But the ones you might be most interested in are the efficiency and the effectiveness, which is obviously efficiency, outputs for your inputs, but effectiveness is really outcomes to inputs. And when you're looking at how you outputs contribute to outcomes, that's really can be quite difficult, because how do you measure those outcomes? And particularly if you're looking at homeopathy, you're saying, well, look, we want to generate these broader benefits. How do we measure them? But there are ways to measure these things, and they are used all the time. I mean, many of you will be familiar with the whole idea of like quality adjusted life years. Now, quality adjusted life years are using a weighting system to show how far an output generates an outcome. And that's basically what a quality adjusted life year is, cost utility analysis, and that's what that's actually doing. But to think about the outcomes, it's not just health. There's been a lot of studies I've seen and read which were really interesting, and they were trying to look at how can we measure improvements in health from people who have undertaken a particular course of treatment. But it is not only improvements in health that matter when you're looking at public money. You're actually looking at general well-being. You're looking at general well-being in society as well. You're looking at costs saved to the individual, not just to say the NHS or whatever. There's all sorts of additional factors that is perfectly legitimate to take into consideration. And to a large extent, there's elements in the calculation of quality adjusted life years that do draw that in. Not completely, but quite a lot. For example, What counts? What could you legitimately include if you're thinking about what benefits does homeopathy give? Again, remember, I'm not looking at anything to do with efficacy or whatever. I'm looking at the fact that patients are reporting that there's improvement, they're feeling better, general well-being, that kind of thing. So yes, health benefits count. But other things do count. I mean, that's like your impact on your family and friends, your own feelings, perceived well-being. That's important, that counts. Improved employment or income chances because you're feeling better. Cost savings to you because you don't have to go for so many appointments, for example. And there's other externalities or public benefits which people think, well, there's a financial element to that, but they count as well, like reduced demand for other services, happier overall levels of citizen well-being, potentially increased tax takes if more people are working, etc. Now, the thing about economic benefit, as I say, it's not purely financial. It tries to capture a whole range of impacts on society. And beyond that, you can actually look at additional social benefit, where, for example, there might be something that affects a particular section of the community more than others, and they're a sort of priority part of the community, in which case you can actually legitimately weight the results. So, for example, the impact on them is given a higher weighting than the impact on another group. And again, the Treasury does this all the time. So if you haven't heard of that idea of socially weighting before, well, the thing is, it happens all the time in public services, so it's totally legitimate and is accepted.
About 5 minutes.
Okay, I'll just round up really. I mean, there's a lot. I mean, I've done a paper for Greg, which I'm sure may be available in due course. But what I did try to do was to say, well, look, with this limited amount of data I've got, I looked at the report, the final consultation report on the Liverpool CCG consultation. As some of you will be aware, you may all be aware, Liverpool was going to continue funding some homeopathy until it received a challenge from the Good Thinking Society, and then it went and did another review and a consultation on whether it should fund homeopathy or not. And the figures involved in that particular thing were they were paying £30,000 a year to contract out to contract some for homeopathy services. Now, this is not exactly a huge amount of money, but never mind, that's what they were paying, is £30,000. So that's the input, and that's actually quite good because you can say, right, they did that to contract, so that's the total cost. The activity was obviously people were referred for assessment and treatment, etc. And the thing is, because it was meant to be a sort of evaluation, they actually gave some data on what was delivered. So there was 121 patient appointments, first initial appointments, 447 follow-up. In terms of outcomes, we didn't have much information for this specific group. There was actually a general survey on their website reporting predominantly almost unanimous patient satisfaction with what they've got, but it was a bit too general. You couldn't really use it. It wasn't done according to any particular framework I could identify. But you could think about, as outcomes, you could think about other examples, like the results from the big Bristol survey and a previous Liverpool survey. Now, I've got here, when I kind of looked at this, I had an economic valuation which came to 49.8 grand. As you'll note, more than the costs. How did I get there? Basically, you had again, you had to identify the outputs, which we did. You had to quantify them, which we had, the number of appointments. Then you had to price them. By pricing them, I shadow priced them. And by shadow pricing them, I did a survey. I looked around at the prices that were being charged in the market for people paying privately for homeopathic consultations. I had 2 or 3 examples. I thought, well, that's fine. And I took an average. And the average, that was for a medically qualified homeopath. So the average came out at £125 for the first appointment and £75 for the other. Now, that's actually a perfectly legitimate way to do it. You look at what's a revealed preference, what people are paying elsewhere. And so then I came up with what the economic value was. And as you can see, the economic value was considerably larger than the actual cost. And that is actually a generic valuation. You can go on, and we couldn't completely do it in this case, to then look at a social valuation where you would actually devise a series of weightings to see is there any additional social value. In the report, I actually was being a bit sort of devil's advocate-y and said, well, you could even reduce the social value, because if you say that only 70% of patients are satisfied from a previous survey, well, perhaps there's only 70% of that value that's really valid, because there's only 70% contributing to the ultimate outcomes. But even then, it's still in excess of the costs. It came up at nearly £5,000 more than the costs, the input costs. So that was really just the example. So I'm just going to wind up now. Again, what I'm trying to do is just to look at it from a different perspective, to say, well, actually, can we change the question? Because everything seems to be going around in a circle. Can we prove it works? Can we get them to understand that actually they need to be a bit more open-minded or whatever? No, let's just say, well, is it worth spending money on? And that's the question that's asked up and down the country every day, and by the Treasury every day. And if you start looking at it that way, it could well be that you will find ways to generate the necessary evidence legitimately. Because this is the thing, I mean, all the stuff that I work on with my colleagues, evidence is really important to us. The reason we've been quite successful in helping higher education is because we stick to official data as much as possible, we stick to recognised methodologies as much as possible, so that what we're saying is credible. And so if you actually look at it using recognised methodologies as much as possible, you may find that actually you're going to be able to answer some of the critics at least, and particularly when you've got a health board looking at shall we continue funding, you can actually force them to look at the economic issues. So, and in particular, I'll just finish off by coming back to NICE. I was looking again at what NICE do. That's the National Institute for Health and Care Excellence, it's called now. All of their methodologies are based on the Treasury Green Book. They're just an extension and extrapolation of them. The whole idea of quality adjusted life years, I mean, they're great because they actually they look at aspects to do with people's quality of life and all the rest of it. And I don't see why that couldn't be applied to homeopathy just as much as it is to any other kind of health treatment. And once you're able to do that, well, to be honest, you're really going to be in a strong position to be able to say, well, right, here you go, here's some evidence. It's done according to your methodologies, and you can compare it. I mean, in every quality adjusted life year at the moment, I think NICE say is worth about £30,000. So you can actually then put it into a context that is accepted officially. You're always still going to get people who having come to this afresh, I was a bit taken aback, people who I would describe as fanatics, who are actually really, really against it. But they will always exist. But the point is, you want to influence the actual policymakers, the people who are making the decisions on funding. They have a duty to spend public money wisely. If there's evidence to show that actually there is broader benefit being generated using recognised methodologies, well, actually you start to have a stronger case. So I will wind up now to see, just to see what people think of looking at it from this sort of different perspective.
Ursula, thank you very much.